to the Kanski lecture series, and this is the Orbit part 2. And today we are going to discuss about the thyroid eye disease, which is one of the very important topic in Kanski. So let's get started. Thyroid eye disease introduction. Thyroid eye disease, also known as thyroid associated orbitopathy and Graves ophthalmopathy, is a very common orbital disorder and is the most common cause of both bilateral and unilateral proptosis in an adult. It is one of the very important line. One might consider that unilateral proptosis, thyroid eye diseases causes the bilateral proptosis, but it is also one of the major causes of the unilateral proptosis as well. So there is a thyrotoxicosis. So there are thyroid hormones like T3 and T4, and TSH is basically the hypothalamus which secretes the TSH and which stimulate the thyroid to produce the hormone T3 and T4. So whenever there are increased in the T3 and T4, there will be the automatically decrease in TSH. So these are one of the laboratory findings of the thyroid disease. Thyrotoxicosis, hyperthyroidism, is a condition involving excessive secretion of thyroid hormone. So thyroid hormones are secreted in excess amount. Grave disease, the most common form of the hyperthyroidism, is an autoimmune disorder in which the IgG antibodies bind to thyroid stimulating receptor in the thyroid gland and stimulate secretion of the thyroid hormone. It is more common in females and may be associated with other autoimmune disorder. So Graves disease is a medical condition in which what happen is that there are certain antibodies that are being produced, that binds to the TSH receptor in the thyroid gland, and what it does is causing the stimulation of the T3 and T4. Presentation is often in the fourth and the fifth decade, with symptoms including weight loss despite good appetite, increased bowel frequency, sweating, heat intolerance, nervousness, irritability, palpitation, weakness, and fatigue. So one thing is important, that it is more common in females, and what is important is that is why most of the cases of the thyroid eye disease are female, because the condition itself is thyroid disease is more prevalent in females. So what are the symptoms of the thyroid disease? So thyroid disease causes the systemic condition, and one of the important role is that the patient will have an increased appetite, increased bowel frequency, they have a loss of weight, and they will having an heat intolerance, they will have a palpitations. So these are one of the signs of the thyroid disease. There may be the enlargement of the thyroid gland, tremor, pallor, erythema, and warm and sweaty skin. Thyroid acropathy is a phenomena similar to the clubbing of the finger. So acropathy means that a nail's deformity that will be present in the case of a thyroid disease, occurring in about 1%. Pretibial myxedema, 1 to 5 centimeter, is indurated thickening of the skin of the shin. So remember that a pretibial myxedema does not mean edema. It means that the shin, this is a leg, and what you can do is this is a foot, and this is a shin, and there is a thickening and induration of the shin area, and this is called the pretibial myxedema. So that is why in case of a thyroid patient, you ask the patient to show their legs, so you can see the pretibial myxedema. Cardiac manifestation may include sinus tachycardia and other arrhythmias. Other autoimmune disorders can be associated. Thyroid function is commonly tested initially with the TSH level. If this is low or normal but thyroid disease is still suspected, a range of additional investigations can be carried out. Treatment options include carbimazole, uracil, propranolol, which is a beta blocker, thyroid ablation with radioactive iodine, and partial thyroidectomy. So basically these are all the treatment that you can do medically and surgically to treat the thyroid condition. Carbimazole, propylthiouracil, and propanol, which is a beta blocker, they both act by decreasing the T3 and TSH, T4. Whereas thyroid ablation is basically you ablate thyroid, so it will produce less thyroid, and you can also do the thyroidectomy as well. So you can see figure 4.9. A is showing us a enlarged goiter, and B is showing the arthropathy, which is like a clubbing of the finger. And now we have a risk factor for ophthalmopathy. So what are the risk factors which increases the ophthalmopathy in a condition with the thyroid? If a patient is suffering from the thyroid disease, so which condition, what are the risk factor which increases the ophthalmopathy? Once a patient has a grave disease, the major clinical risk factor for developing thyroid eye disease is smoking. Very important. The greater the number of cigarettes smoked per day, the greater the risk, and giving up smoking seems to reduce the risk. Women are 5 times more likely to be affected by thyroid eye disease than men, but this largely reflects the increased incidence of the grave disease in women. We discussed this point already. So, smoking is one of the risk factors. So, you ask the patient to cessate smoking in case of a thyroid disease. Radioactive iodine, which used to treat hyperthyroidism, can worsen the thyroid eye disease. It is also a very important point. This condition is also, although less commonly occurring in euthyroid and hypothyroid, including treated hyperthyroid patient, it can sometimes be the presenting manifestation of the thyroid related disease. So what are the pathogenesis of the ophthalmopathy? So what causes the eye signs in a case of a thyroid disease? So thyroid ophthalmopathy involves an organ specific autoimmune reaction in which the antibody that react against the thyroid gland cells and orbital fibroblasts leads to the inflammation of the extraocular muscles, interstitial tissue, orbital fat, and lacrimal gland, characterized by the pleomorphic cellular infiltration associated with increased secretion of the glycosa, aminoglycans, and osmotic imbibition of the water. So basically, in the antibodies which are produced against the thyroid gland also react to the orbital fibroblast, which leads to the inflammation of the muscles, interstitial tissue, orbital fat, and lacrimal gland. And whenever you do the histopathology, what it will show? It will show the cellular infiltration. There will be the increased secretion of the glycosa, aminoglycan, and the osmotic imbibition of water. There is increase in the volume of the orbital content, particularly in the muscle, which can swell up to 8 times their normal size. There may be secondary elevation of the intraorbital pressure, and the optic nerve may be compressed. Subsequent degeneration of the muscle fiber leads to the fibrosis, which exert a teething effect on the involved muscle, resulting in restrictive myopathy and diplopia. So there are two stages of the thyroid disease. One is the inflammatory stage and other is a fibrotic stage. So in inflammatory stage, there will be the acute inflammation, and whenever the acute inflammation settle down, it can lead to the fibrosis stage, which could lead to involve the muscle, and when it will involve the muscle, it can lead to restrictive myopathy, and it can also lead to diplopia. So what are the clinical features of the thyroid eye disease? Introduction. Thyroid eye disease typically proceeds through a congestive inflammatory stage in which the eyes are red and painful. These tend to remit within 1 to 3 years, and only about 10% of the patient develop serious long-term ocular problems. A fibrotic quiescent stage follows, in which the eyes are white, although the paleness motility defect may be present. So, how will you know that a patient is present as to with a active thyroid disease, inflammatory eye disease, and or a chronic? So, why we need to understand this thing? Because in case of if the patient is having an active inflammation, if we give the steroid, it can be effective. But if a patient presents with a chronic stage, giving a steroid is not beneficial in the case. Like for example, if a patient is only present to us with the proptosis, with the long term proptosis, then giving a steroid will not be helpful. But in case of the active inflammation, the eyes are red and painful, the giving steroid can be helpful. So there are two stages, inflammatory and there are fibrotic stages. And in the inflammatory stages, the eyes are usually red and painful. Clinical features broadly can be characterized into soft tissue involvement, lid retraction, proptosis, optic neuropathy, and restrictive myopathy. So these are the different stages a patient can present to us. Involvement, only soft tissue can be involved. There can be the lid retraction, there can be proptosis, optic neuropathy, and restrictive myopathy. A commonly used classification for the severity of the thyroid eye disease has been issued by the European Group on Graves orbitopathy, UGOGO, sight threatening due to optic neuropathy or corneal breakdown, moderate to severe with one of the moderate to severe soft tissue involvement, lid retraction of 2 mm or more, diplopia and proptosis of 3 mm or more, mild only with a minor impact on the daily life. So according to the UGOGO classification, there are three types: mild, moderate, and severe. So severe, we know that if there is an optic neuropathy or exposure keratopathy, it is severe. Mild is where there is an small impact in the daily life, and moderate is when there is a lid retraction of 2 mm more and proptosis of 3 mm or more. So what are the symptoms and signs of the soft tissue involvement? Symptoms are soft tissue involvement are grittiness, red eyes, lacrimation, photophobia, puffy lids, and retrobulbar discomfort. So a patient with a soft tissue involvement will present to you with swelling of the eyelids. It can also present to you with the red conjunctival congestion, red eyes, lacrimation, and there will be the photophobia. Signs may include epibulbar hyperemia. This is a sensitive sign of inflammatory activity. Intense focal hyperemia may outline the insertion of the horizontal recti. Very important. So you can epibulbar hyperemia. We can see figure 4.10a. So what happen is that there is a hyperemia of the conjunctiva and it is lying on the insertion of the recti muscle. B is showing us the periorbital edema. So you can see the edema outside the lids. There is a chemosis, there is a swelling of the conjunctiva as well, and there is a prolapse of the fat into the eyelid. And C is showing us the superior limbic keratoconjunctivitis. So periorbital swelling is caused by the edema and infiltration behind the orbital septum. This may be associated with chemosis and prolapse of the retroseptal fat into the eyelids. Tear insufficiency and instability is common. Corneal signs are exacerbated by the lid retraction and can include punctate epithelial erosion, superior limbic keratoconjunctivitis, and occasionally bacterial keratitis, thinning, and scouring. So that these are all the signs of the soft tissue involvement. Then there can be the lid retraction that can be associated with thyroid eye disease, and why it happens is because of the molar muscles, because the molar muscles are getting overstimulated because uh, because of the sympathetic overstimulation which occurs due to the thyroid hormones. Retraction of the upper and lower lid occur in about 50% of the patient with the Graves' disease. So it is very common sign. Overaction of the molar muscle is postulated to occur as a result of a sympathetic overstimulation secondary to the high levels of thyroid hormones. Fibrotic contracture of the levator palpebrae and inferior rectus muscle associated with adhesion to the overlying orbital tissue is another probable mechanism, together with the secondary overaction in response to the hypo and hypertropia produced by fibrosis. So another postulation is that whenever there is a contracture of the levator palpebrae, which is causing the elevation of the lid, it can also cause the elevation of the secondary overaction of the lid. Whenever there is a contraction of the inferior rectus muscle, it can also causes uh, um, lower the lower lid also get retracted. So what are the symptoms of the lid retraction? Patient may complain of a staring or bulging eyed appearance, difficulty closing the eyes, and ocular surface symptoms. So there will be the symptoms of the dry eye, and the patient will say that they have some scary gaze, and also that they have a difficulty in opening the eye. So you know that the cornea, the upper lid lie almost 2 mm below the superior limbus, and the lower lid also lie at or 1 mm above the lower limbus. So whenever there is a scleral show, you can say that it is a case of a lid retraction. The upper lid margin normally rests 2 mm below the limbus. Lid retraction is suspected when the lid margin is either level with or above the superior limbus, allowing sclera to be visible. Scleral show. The lower eyelid margin normally rests at the inferior limbus. Retraction is suspected when the sclera show below the limbus. Lid retraction may occur in isolation or in association with proptosis, which exaggerates its severity. The Dahl-Rempel sign is lid retraction in primary gaze. The Kocher sign describes a staring or a frightened appearance of the eyes, which in particularly marked on attentive fixation. The von Graefe sign signifies retarded descent of the upper lid on down goes lid lag. So there are certain eye signs. So whenever the patient is just looking normally straight ahead and there is a lid retraction, so you can call it a Dahl-Rempel sign. And whenever you ask the patient to look somewhere or fixate at a point, and they have a staring and a frightened appearance of the eyes, this is called the Kucher sign. And von Graefe sign is when you ask the patient to look down and there is a lid lag, this is called the uh, von Graefe sign. So you can see the signs here. So these are the mild left lid retraction, mild left lid retraction. B is showing the bilateral, moderate bilateral asymmetrical lid retraction in primary gaze, so it is a Dahl-Rempel sign. And C is showing the severe lid retraction, Kucher sign on staring gaze, uh, and there is on looking down, there is a lid lag of the right eye. This is called the von Graefe sign. Proptosis symptoms are similar to those of the lid retraction. Proptosis is axial, unilateral, or bilateral, symmetrical or asymmetrical, and frequently permanent. So, the proptosis can be unilateral, it can be bilateral, it can be symmetrical, and it can be asymmetrical. But one thing is that the proptosis is usually axial. Severe proptosis may compromise the lid closure along with the lid retraction, and tear dysfunction can lead to exposure keratopathy and corneal ulceration and infection. Uh, so these are the 4.12, and it is showing the proptosis in thyroid eye disease. A is showing the symmetrical proptosis, B is showing asymmetrical because the left eye is more proptosed than the right eye, and B is showing the bacterial keratitis due to severe exposure. Then there is a restrictive myopathy. Restrictive myopathy is that a patient is unable to move the eye in a different direction of the gaze due to the restriction or fibrosis of the muscle. Between 30% and 50% of the patient with the thyroid eye disease develop ophthalmoplegia, and this may be permanent. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. So that is why it's important to rule out, because in the case of inflammatory edema, you can give steroid, but in fibrosis, it is not benefited by the steroid. Double vision symptoms include double vision, often discomfort in position of gaze, signs in approximately order of frequency. So one thing you must remember, that restriction is slightly different from palsy. So whenever there is a palsy of the muscle, it causes the elevation defect in the movement of that action of that muscle. For example, in the case of a superior rectus palsy, the patient is unable to move the eye in the superior case. So it is slightly different because in a case of the inferior rectus contracture, for example, in a case of a superior rectus contracture, or there is a fibrosis, the patient is unable to move the eye downward. Why? Because the superior rectus muscle is contracting the eye in the upward direction, so the patient is unable to move the eye in the inferior direction. So the order of frequency is inferior, medial, superior, and lateral IMSL. So elevation defect caused by the fibrotic contraction of the inferior rectus may mimic superior rectus palsy and is the most common motility defect. So you can see that in this case the inferior rectus muscle is contracted, but there is an elevation defect. Abduction defect due to fibrosis on the medial rectus, which may stimulate this sixth nerve palsy. Depression defect secondary to the fibrosis of the superior rectus. Adduction defect caused by the fibrosis of the lateral rectus. So we can see figure 4.13. It is showing us the restrictive thyroid myopathy, and A is showing the defective elevation mainly of the right eye, and B is showing the reduced depression of the right eye secondary to the fibrosis of the right superior rectus, and C is showing the defective elevation of the left eye in the same patient shown. So next is the optic neuropathy. So optic neuropathy, why it occurs? Basically when the muscles are, so you know that there is a common tendinous ring and through it passes the optic nerve, and whenever the muscles are enlarged so much, it causes the compression of the optic nerve. So that is why the neuropathy develop in case of the thyroid eye disease. Optic neuropathy is fairly common, up to 6%. Serious complication caused by the compression of the optic nerve or its blood supply and the orbital apex by the congested and enlarged recti and swollen orbital tissue. Such compression, which may occur in the absence of significant proptosis, may lead to severe visual impairment if adequate and timely treatment is not instituted. In thyroid eye disease, compression of the optic nerve secondary to enlarged and congested rectus muscle may occur in the absence of proptosis. Symptoms: impairment of the central vision occur in conjunction with the other symptoms of thyroid eye disease. In order to detect early involvement, patients should be advised to monitor their own visual function by the alternatingly occluding each eye, reading small print, assessing the intensity of the color, for example, on a television screen. So there are 5 things which are defective in case of optic neuropathy. Usually 5 things. One will be the visual acuity, second will be the visual fields, third will be the color vision, fourth will be the contrast sensitivity, and fifth will be the light brightness perception. So visual field will be decreased, visual field will be decreased, there will be a color vision defect, there can be the decrease in the contrast sensitivity, and the light brightness perception is that the light brightness will not be the same in the both eyes. A high index of suspicion should be maintained for the optic neuropathy, and it is another thing is an RAPD also will be present in case of a optic neuropathy. Sixth thing, a high index of suspicion should be maintained for optic neuropathy and is important not to mistakenly attribute disproportionate visual loss to minor disease. Visual acuity is usually reduced but not invariably. Color desaturation is a sensitive feature. There may be diminished light brightness perception appreciation. A relative afferent pupillary defect, if present, should give cause for a marked concern. Visual field defect can be central or paracentral and may be combined with the nerve fiber bundle defect. These findings, in concert with the elevated IOP, may be confused with primary one-angle glaucoma. The optic disc may be normal, swollen, or rarely atrophic. Investigations other than a blood test for thyroid eye disease are not necessary if the diagnosis is evident clinically. but the exclusion of other condition is sometimes indicated. Visual field testing is carried out if there is a suspicion of the optic nerve compromise and may be performed as a part of the baseline evaluation if even if there is no apparent visual impairment. So visual field test can be done as a baseline test to check for any kind of optic neuropathy. MRI, CT, and ultrasonographic imaging of the orbits are indicated in some circumstances, such as helping to confirm an equivocal diagnosis by identification of the typical pattern of the extraocular muscle involvement in thyroid eye diseases, consisting of the muscle belly enlargement with the tendon spinning. So, very particular sign of the thyroid eye disease in a CT scan will be the Coca-Cola sign. So, what is the Coca-Cola sign? Is that there will be the muscle enlargement, but there will be the spinning of the tendon. Imaging is also used in the assessment of the optic nerve compression and prior to the orbital wall surgery. Visual evoked potentials are sometimes utilized in optic neuropathy. So these are some of the investigations that you can carry out in case of thyroid eye disease, but more important thing is how you will treat the patient with a thyroid eye disease. Very important. When to give a steroid and when not to give a steroid. So the thing is, you ask the patient to do certain measures, that you ask the patient to take the smoking cessation, and you ask the patient to treat their thyroid disease. These are the two important things that you should do. But when to give the steroid is a question, and it depends on the clinical activity score. And clinical activity score have a points. So whenever 3 out of 7 are positive, you have to give a patient a steroid. Treatment can be classified into that of a mild disease, most patient, moderate to severe active disease, and a treatment of the post-inflammatory complication. The first measure taken in all cases should be cessation of the smoking. Thyroid dysfunction should be also be managed adequately. If radioiodine treatment is administered in a patient with a pre-existing thyroid disease, a short course of oral steroid should be given a concert. So why is it important? Because iodine treatment is a risk factor for the thyroid disease. So whenever it is given in case of a thyroid disease, you may give steroid in that patient as well. So how do you treat the mild diseases? Mild diseases when there is a soft tissue swelling and there is nothing much of a impurity. So you just treat it with lubrication. You ask the patient to tape the eyelid. You ask the patient to elevate the head with the pillows during the night, and you can give the topical anti-inflammatory as well. So mild diseases, lubricants for the superior limbal keratoconjunctivitis, corneal exposure and dryness. Topical anti-inflammatory agents, steroid and non-steroidal anti-inflammatory drugs, NSAIDs and cyclosporin are indicated by some authorities. Head elevation with 3 pillows during sleep to reduce periorbital edema. Eyelid taping during sleep may elevate mild exposure keratopathy. So mild to severe disease, active disease, so it is the disease where you can give the steroid, and that depends on the clinical activity score. Clinical activity score, you go suggest calculating a clinically activity score to aid in determining a threshold for the use of the immunosuppressive, assessing 1 point for each feature present from the following list, and considering for a score 3 or more out of 7. So there can be eye pain on eye movement. There is eyelid, there is conjunctiva, and there is a movement. So whenever there is a spontaneous orbital pain, there will be the 0.1, and whenever there is a gaze evoked pain, it is a also given 0.1. There will be the swelling. If the eyelid is swollen, it is giving the 0.1. If the eyelid is red, it is giving 0.1. If the conjunctiva is swell or chemosed, it is given 0.1. It is red, it is given 0.1. Another thing is inflammation of the truncle, which is also involved in the conjunctiva. So 1 point for the spontaneous orbital pain, 1 point for the second is the grazed port orbital pain, eyelid swelling considered to be due to active inflammatory phase, thyroid disease, eyelid erythema, conjunctival redness considered to be due to active inflammatory phase, TED, chemosis. 7 is inflammation of the truncle or plica. During subsequent visit, a point is allocated for an increase in proptosis of 2 mm or more, a decrease in uniocular excursion in any direction of 8 degree or more, a decrease in a Snellen acuity of 1 line. So 3 more points are added during the subsequent visit if the proptosis is increased 2 mm or more on subsequent visit, and there is a decrease in a movement by 8 degree or more in a subsequent visit, and a decrease in a Snellen acuity line, 1 line. It is also known given as a 1 point. So whenever the if the patient score 3 in the points, we start the systemic steroids. Systemic steroids are the mainstay of the treatment for the moderate to severe disease. Oral prednisolone 60 to 80 milligram per day may be given initially and tapered depending on the response. Intravenous methylprednisolone is often reserved for acute compressive optic neuropathy, but tolerability is better and outcomes may be superior compared with the oral treatment. So you can also give the IV steroid, but it is usually given in a case of a optic neuropathy. A lower intensity regime in the absence of a acute sight-threatening disease is 0.5 gram once weekly for 6 weeks, followed by 0.25 gram once weekly for 6 weeks. A reduction in discomfort, chemosis, and periorbital edema usually occur within for 24 hours with a maximal response within 2 to 8 weeks. Ideally, oral steroid therapy should be discontinued after several months, but long-term low-dose maintenance may be necessary. So there is a regime in which we give a low intensity for the in the absence of a acute sight threatening. What we give is we give the 0.5 gram once weekly for 6 weeks, and then we give 0.25 gram once weekly for 6 weeks as well. So these are the low dose regime. It is given IV. Second is the orbital steroid injections are occasionally used in selected cases to minimize systemic side effect, but are typically considerable less effective than systemic treatment. So low dose fractionated radiotherapy is also considered less as compared to the steroid, but it can be used when there is a contraindication to steroid or when the steroids are ineffective. Low dose fractionated radiotherapy may be used in addition to steroid or when steroids are contraindicated or ineffective, but because of the delayed effect is not used as the sole treatment of acute optic nerve compression. A positive response is usually evident within 6 weeks. So you know that steroids start responding within 24 hours, whereas radioactive radiation effect after 6 weeks. So it is not given because of the delayed effect. A positive response is usually evident within 6 weeks with a maximal improvement by 4 months. Around 40% will not respond. Adverse effect will include cataract, radiation retinopathy, optic neuropathy, and an increased risk of local cancer. The threshold for its use should be higher in a younger patient and diabetes, the later because of the possibility increased risk of retinopathy. So these are all the cases of the complications of the radiation therapy. You know that it causes optic neuropathy, cataract, dryness, nasolacrimal duct blockage. It can also cause the retinopathy, but the more risk factors are that a younger patient and a diabetic patient. Combined therapy with irradiation, azathioprine, and low-dose prednisolone may be more effective than steroid or radioactive radiotherapy alone. So it is a triple regime which is more effective than a radiotherapy. Immunosuppression in active inflammatory phase of the thyroid disease is important to reduce acute inflammation and to prevent the long-term complication. So these are some CT scans. 4.14 is showing us the muscle enlargement in thyroid disease. A is showing the axial view, showing the fusiform enlargement of the medial rectus muscle. B is showing the coronal view, showing symmetrical involvement of the medial superior and inferior rectus muscle as well as the superior oblique muscles. And 4.15 is showing us the axial CT following bilateral, lateral and medial wall decompression. So you know that a lateral wall is also decompressed and a medial wall is also decompressed. So how will you treat a patient if a patient comes with the optic neuropathy? Optic neuropathy and less commonly intractable corneal exposure requires aggressive treatment. Pulsed intravenous methylprednisolone is commonly used. Regimes including 0.5 to 1 gram on 3 successive days with conversion to oral treatment 40 milligram per day prednisolone, or 0.5 to 1 gram on alternate days 3 to 5 6 times, keeping the maximum dose below 8 gram to reduce the risk of liver compromise, followed by oral prednisolone. So you start giving the pulse therapy in a case of the optic neuropathy. So how will you give it? You give 1 gram for 3 consecutive days and then you start the oral steroid. Another regime is that you give a 0.5 gram or 1 gram on alternate days 3 times and then you start with the oral steroid. Appropriate monitoring should be instituted, including liver function tests as well as gastric protective treatment and osteoporosis prophylaxis if necessary. Orbital wall decompression or orbital apex decompression may be considered if steroids are ineffective. 20% receiving intravenous treatment or contraindicated. Orbital radiotherapy may also be administered but is generally only used as an adjunct to other modalities. Several drugs targeting the specific aspects of immune response in TED are under investigation, notably monoclonal antibody treatment with rituximab and teprotumumab. So these are new drugs that are being used for the inflammatory stage. Rituximab and teprotumumab. Teprotumumab is an inhibitor of the insulin-like growth factor 1 receptor IGF-1R and is effective in reducing proptosis and clinically activity score in patients with TED. Post-inflammatory complication, eyelid surgery should be performed only after any necessary orbital and then strabismus procedure have been undertaken, as orbital decompression may impact both ocular motility and eyelid position, and extraocular muscle surgery may affect the lid position. Surgical orbital decompression should be considered when there is a sight-threatening compressive optic neuropathy in a thyroid eye disease. So now we are moving to the fibrotic stage. When a patient is present to us with the fibrotic stage and there is a significant proptosis or there is a restrictive myopathy or there is a lid retraction. So these are the things that are patient present after the chronic stage. So how will you treat it? First is a patient present to us with the all the three conditions. So which surgery to perform first? So this is one of the important MCQs. We will form the proptosis first, then we will correct the muscle surgery, and then we will correct the lid retraction, because if we do proptosis surgery, it will affect the mobility of the muscles. So when you do the proptosis surgery, then you consider the myopathy surgery, and after that you consider the lid retraction surgery. After active inflammation has remitted, the patient can be left with the cosmetically and functionally significant proptosis, the treatment of which is essentially surgical. Surgical decompression increases the volume of the orbit by removing the bony wall and may be combined with the removal of orbital fat. Most surgery is undertaken by an external approach through a medial wall, and the medial part of the floor can be reached endoscopically. One wall deep lateral decompression is effective, approximately 4 to 5 mm reduction in proptosis, and may reduce the risk of the postoperative diplopia. So there can be the one wall procedure, 1, 2, 3 or 4 wall procedure. In the one wall, the lateral wall is being reduced, and in the two wall, medial and lateral are decompressed, and in 3 wall there will be the uh, floor uh, uh, floor will be removed, and in the 4 wall roof will be removed. So in one wall, deep lateral decompression is effective, approximately 4 to 5 reduction in proptosis. So if you remove the one wall, it will reduce proptosis up to 4 to 5 and may reduce the risk of the postoperative diplopia. Two wall balanced medial and lateral decompression provides a greater effect, but with a significant risk of include diplopia, inducing diplopia. Three wall decompression include the floor with the reduction of the proptosis up to 6 to 10 So you see that after three wall, the proptosis reduction we can lead to 6 to 10 but may lead to hypoglobus and carries a higher risk of infraorbital nerve damage and diplopia. So with the greater wall removal, there are the greater complications as well. Very severe proptosis may require removal of the part of the orbital roof in addition, which is also known as a four wall decompression. Then we go to the restrictive myopathy. There are certain indications for treating the restrictive myopathy. First is the patient complains of the diplopia in the reading or the primary position of the gaze, and there the inflammation stage has been stable for 6 to 12 months. Surgery is required in most cases experiencing persistent diplopia in the primary or the reading position of the gaze, provided the inflammatory stage has been subsided and the angle of deviation has been stable for at least 6 to 12 months. Until these criteria are met, diplopia may be elevated, if possible with prisms or sometimes with botox toxin. So, if the patient complains of the diplopia, you can treat it temporarily with the botox or with the prism as well. The goal of operative treatment is to achieve binocular single vision in the primary and the reading position. Restrictive myopathy often precludes binocularity in all position of cases, though with time the field of the binocular single vision may enlarge as a result of increasing fusional divergences. So in case of a restrictive pathology, restrictive myopathy, and you want to do the surgery on the muscles, you always do recession. You will not do resection, and we do recession with the adjustable sutures. Recession of the inferior or the medial recti is the most commonly indicated surgery. A rectus muscle is never resected, only recessed in thyroid eye disease. Generally utilizing adjustable sutures, the suture is later adjusted later the same day or on the first post-operative day to achieve the optimal alignment, and the patient is encouraged subsequently to practice achieving single vision with consistently accessible targets such as television. So after that, we treat the lid retraction. Mild lid retraction frequently improves spontaneously, so does not require treatment. Control of hyperthyroidism may also be beneficial. Botulism toxin injection to the levator, aponeurosis, and mullar muscle may be used as a temporary measure in patient awaiting definitive correction. So you can give the Botox injection in the levator or mullar muscle to induce the ptosis in a case of lid retraction. Mullerotomy or disinsertion of the mullar muscle is effective for mild lid retraction, but more severe cases may also require recession or disinsertion of the levator, aponeurosis, and the accessory ligament of the superior conjunctival fornix. So what do? You do the mullar muscle disinsertion, because the mullar muscle is overacting. You disinsert the muscle, it will induce the ptosis. And in the severe cases, you can also do the disinsertion or recession of the levator, aponeurosis as well. Recession of the lid retractors, lower lid retractor with or without hard pellet graft can be used when the retraction of the lower lid is 2 or more. So that's it for the orbit part 2. See you in the next lecture.